Hello there. How are you guys? A very good evening. Am I audible to all of you? Hello.
Hello there.
Yeah, I'm very well audible. Yeah, I'm early. I'm all the time early in the class just to do a chit chat with you guys. What is the cause of the UTOS phenomena? What we found somewhere in a hot climate, especially, there was a redistribution of the channels which are there on the peripheral or sorry, the center nerves. Okay, like the sodium, like the potassium. So what happens once the myelin is lost on any nerve tissue and we try to redistribute the channels in of sodium and potassium on that particular nerve, especially in a hot climate. Suddenly that part of the nerve where the redistribution will occur, that particular area of the nerve will always perceive more sensation. So it is a kind of a thing, for example, in a hot climate, the patient might have a sudden visual loss, one, or can I also have a sense of paresthesia as a sensory complaint? So it all happens due to some redistribution of channels in a hot climate on a unmyelinated kind of, or rather a demyelinated kind of a nerve. Okay, louder, louder. I'm very loud. See, Uthoff phenomena in a patient with optic neuritis is something which is suggestive of demyelinating lesion, that is the multiple sclerosis. Remember this way. Yeah, I was stressing on this concept yesterday that the axons are pretty normal in patients. See, what happens is there is demyelination on the axon, but at that point there is no remyelination seen, and rather a scarring occurs on that particular axon. So the axonal nature as such is intact, but somewhere the scarring later on in advanced stages will try to degrade the axon also. So what is the book description in the Harrison? It likely want to explain this, that the axonal architecture may be maintained internally in patients of MS. It's just the demyelination following inflammation, and at that point no remyelination and rather scarring occurring. Okay. Alzheimer I'll take in the live classroom sessions when we discuss that topic there. 1.5 syndrome, I think so. Is something that will be taught in Opthal better. Okay, or we when we meet each other in the live classroom sessions, we will come across all these 1.5 syndrome, especially. Okay. Okay. See, what happens is in Webino, we try to catch an impulse from the opposite frontal eye field. See, these are the two eyeballs. They have got a sixth cranial nerve which is located in pons, which is connected to the frontal eye field of the opposite side like this. Correct? So both of them catch and they try to take the eyeball laterally like this. Okay. Now the question comes in, sir, why is the eyeball central? Look at me. If this frontal eye field is working, correct, the eyeballs are going to go this way, right? If this frontal eye field of mine is working, the eyeballs are going to go this way. Now both of them are working equally, correct? And what do you have? Nullification of each other's effect. But the thing is most important. When the sixth of this side moves the eyeball abduct, this adducts because there is a rope hanging between the two upside down medial longitudinal fascicle. Same as the MLF from this side also. Now this rope is broken. That means the sixth cranial nerve on this side is going to catch the signal from the opposite frontal eye field, and sixth of this side is going to catch it from the frontal eye field. And now what happens? There is no third cranial movement. Only the six independently move, even though the frontal eye fields are equal in firing. That means even in the central gaze of the patient, they might look like this towards the wall eye effect. Okay. How much CNS is left? We are left with one chapter. A lot of CNS is left, my dear friend. It's a never-ending topic. It's like Suryavansham of all the topics. We'll try to catch up with you guys in the live classroom sessions also later on. Okay. Shadow plaques and all these things you'll come across in radio classes. Don't worry. A lot of things are in radio to be discussed in MS. Yeah, I've discussed this with the pharma faculty. They say mitoxantron. I'll update you. Don't worry. Don't worry. Yeah, I see. I was today very busy in not making memes, but making your question paper. Okay, so I'm just made the question paper. I think so by midnight. It should go live on the app. And tomorrow when we'll see each other, I'll try to discuss some questions from that question paper also. Okay. And all these things somewhere in the question paper that I put will be from the topics that we have covered in these Medico's lectures. Okay. So topics that we have done, number one topic, seizure disorder, headache, CNS infection, aphasia. Today we are going to do Parkinsonism and multiple sclerosis. Okay. You may not get questions on every topic because there was a limitation of 50 questions. So some topics which are really very important, I've tried to put questions over there. So by midnight, I think so I'm just working on that thing since morning. That's why I was not able to answer any of your queries on the Medicos app. Okay. Right. Very sad news. Irfan Khan, a very great actor, passed away today. As Rajesh Khanna dialogue goes in for this now, हम रंगमंच की कठपुतलियां हैं और डोर ऊपर वाले के हाथ में है. Okay, so rest in peace, Irfan. Let's start the class. We're right on time. Sleeping at 7:30 p.m. No, I'm not going to do that. I'm going to study on the eMedicos app, right? Okay, let's begin. Let's begin with a very simple concept of basal ganglia. How is basal ganglia being made and why does it really function? Okay. Let me start from the very basic, the anatomy first. So let me tell you a basic anatomy and function of basal ganglia and how does it really function to bring about a particular kind of a movement, right? Now, if you remember, basal ganglia works like a secretary of the cortex. So we get a part of the brain which is known as a cortex. Okay. So we are dealing with basal ganglia disorders today. A mighty important topic anytime. A lot of questions and more clinical than any topic till now. Okay. So be careful. So the cortex is going to develop a particular command that I am going to do. Now, if you look at the cortex anatomically, it is made up of two parts. One is a motor cortex and the second one happens to be the premotor cortex. Look at this name, motor, premotor. Okay. If you know the motor cortex in the brain is having a motor area where all the motor commands are going to start. And now I'm going to move my body. If I plan to do an activity, of course, I'm going to do a particular activity because I've done a planning in the brain and I'm going to execute it by the movements of the muscles required for that movement. Okay. If you know the connection part, the motor cortex anytime is connected with the body with the help of a track, which I know as the pyramidal or the corticospinal tract. Now don't ask me the abbreviation full form. It's very simple. CS stands for the corticospinal tract. Okay, but remember this, the premotor area. Now the premotor area is also giving rise to a particular tract which is known as an extrapyramidal tract. So there are two tracts with me. One is the pyramidal, one is the extrapyramidal tract, which are going to work in conjugation with each other and help me to move the body. Okay. Now the point here is, what is this extrapyramidal tract going to do? It is going to give me a signal in a secretary of the brain that is known as the basal ganglia. Remember this. Now the basal ganglia of the brain is going to receive a signal from the premotor cortex through the extrapyramidal tract. And now what will happen? It is going to send signal back to the motor area. Two signals will go back to the motor area. Right? Remember this. One signal which will go back to the motor cortex is a stimulatory signal. One signal which will go back to the motor cortex is going to be an inhibitory signal. So look at a circuit-like thing. The cortex is not only a motor cortex, it's also a premotor cortex. Now this premotor cortex or the premotor area is generating an extrapyramidal tract which comes down to the secretary of the cortex known as basal ganglia, which regulates the cortex by stimulation or inhibition. Correct. Now that's the very basic, no hi-fi drama into this. But how is the basal ganglia made up of? Okay. How is the basal ganglia made up of? What kind of structures are there in the basal ganglia? Let me draw a coronal section of the basal ganglia. You'll understand the structures inside it better, because that basic anatomy is required to understand this topic. So if I take this as a midline, a dotted line as a midline, correct? We're going to have the cortex above, and below the cortex at the base of it, there are some ganglias which are there, right? Which are chains of neurons which are sitting there and regulating the cortex above. But what is the basal ganglia all made up of? A lot of nucleus at the base of the brain. Find this out. There's one structure somewhere which is near the midline in the basal ganglia. So we are trying to make a section of basal ganglia, a conal section in which one structure which is functionally inside the basal ganglia somewhere near the midline, if I take this dotted line as a midline, is the thalamus, right? Lateral to this, there is a lens-shaped nucleus sitting, okay? Now this nucleus has got a name with it as a lentiform nucleus. Lentiform nucleus, right? Now remember this, the lentiform nucleus, some people know it, is known as made up of two structures. One is the globus pallidus, the outer part of it. Yes, sorry, I'm very sorry. Very sorry. Putamen. Yes, the outer peripheral part of it. And then second, the medial part is the globus pallidus. I can abbreviate as the word GP. Okay. Now this globus pallidus is made up of two more structures inside it. That's the globus pallidus externa, E. That's the E over there. Okay, it's not the C, it's E. It's not coming properly. Okay, because it's in English, E for English, and you know my English. Globus pallidus I. I means interna. Okay. So globus pallidus externa and interna are the two parts of the globus pallidus, which is a part of the lentiform nucleus. And the outer peripheral, that is a lateral part, is the putamen. Okay. Some people do spell it as putamen. That's fine. But in Punjabi, I always call it as putamen. Thalamus, the medialmost part. Somewhere we find this part also. There's a very small kind of a thing sitting with a head over there. Can you tell me what structure am I pointing to? It's a very simple structure. What structure is this? This structure is nothing but the head of a nucleus known as the comma-shaped caudate nucleus. Right? Below this in the coronal section, yes, below this the thalamus, below that is a structure which is known as a subthalamic nucleus. Subthalamic nucleus, I can abbreviate very commonly this as STN. Okay, good. Some people are late for the class. They're always on the time for a movie or some comedy show. How many pages to leave? You can leave 100 pages because you have to read 100 pages of anatomy. Do not read 100 pages of neuroanatomy. Follow the diagram. It's very simple. Some people are writing, so please repeat. I'll repeat at the end. Don't worry. Please be with me at least on this topic. Okay, this is a very simple topic. See, neuroanatomy I know is like biochemistry. Why? It's a Chinese movie and a Russian subtitle. Like a Parasite movie if you're watching in a Russian subtitle, which is in a Korean language maybe. So what will you understand in hearing? Nothing. What you will understand in seeing is nothing. So somewhere I always found the neuroanatomy being the most dreaded part of neurology. Chinese movie in a Russian subtitle. Try to understand this in your own vernacular language. It's a very simple thing. Okay, and don't be a fool in the classroom. Have an IQ on these topics. It's very simple. Now, can you tell me somewhere that there's something which is sitting right over there? I'm marking this as with the blue. Okay. Can you tell me what structure is somewhere between the lentiform nucleus and the thalamus? There's a structure which is a capsule which is present internally in the basal ganglia. Okay. What is that structure? Yes, some people know it. That structure is nothing but your internal capsule. Internal capsule. Yes, good. People are there with me? Good. Right. So that's the internal capsule kind of a thing that we find sandwiched between the lentiform nucleus and the thalamus. Okay. Right. So this is the basics of a basal ganglia, but I'm still not complete. Why I'm still not complete? Because below this, there is going to be a structure. A structure in a transverse section, if I can make it as a midbrain, which is anatomically different but functionally a part of the basal ganglia. Yes. If you know the midbrain is carrying down or giving rise to two cranial nerve nucleus, the third and the fourth. But it also helps me to connect the brain with the body. Because in the interior part of it, there is an anterior part of it which is having a corticospinal tract coming down. Look at this now. Motor cortex is giving rise to a corticospinal tract which is coming down in the internal capsule and going down into the midbrain, down. So maybe I can see a corticospinal tract running in the interior part of the midbrain. Now if I look at this anatomically, this part is going to be the anterior part. See, I'm not drawing a coronal section this time. I'm trying to make it in a transverse section. So please be attentive on this. Above we have made a coronal. This one happens to be a transverse section of the midbrain. Now, can someone of you tell me? Good. Some people know there's a deeply pigmented structure over there. Yes. Very good. Some people know that's name is known as substantia nigra. Okay. Good. Some people want me to repeat. I know it's neuroanatomy. 100 times even if you read it, you will not be able to understand it. Try to understand it at once. Simple. Basal ganglia disorders, how are they going to affect the patient? The cortex is made up of two parts, the premotor and the motor. The motor cortex gives rise to the pyramidal tract corticospinal. The premotor goes into the extrapyramidal tract, goes to the basal ganglia which stimulates the cortex or inhibits the cortex. I'll come back to this again. Cortex below is the basal ganglia made up of two major parts, the lentiform nucleus and the thalamus. Lentiform nucleus has got an outer peripheral part, that's the putamen, and globus pallidus. Then the thalamus, and above is a caudate nucleus. Below is a subthalamic nucleus. Between the lentiform nucleus and the thalamus is a sandwich internal capsule. Below is a very important part, midbrain, which is having substantia nigra over there. Okay. I'll come back to this diagram very often today because this is the very basic that we need to understand. Now, why does a movement disorder happen? Look at this now. If I think of doing an activity, either the activity can be very fast or the activity can be very slow. For example, I want to just pick up the mobile phone. I'll take my hand fast over there or maybe slow, one thing. Or maybe the whole trajectory is altered, right? Let me show this to you. What are the movement disorders that we classically see in a basal ganglia lesion? movement disorders, right? The very first movement disorder is ethetosis. Now, to define ethetosis in a very simple language, it is defined to me as a slow crawling movement. Okay, it's a slow crawling movement somewhere seen in the distal limb. So remember this. There are some movement disorders like this. Write it down, ethetosis. It's a slow crawling kind of a movement in the distal limb. Okay. Now, how does ethetosis actually look like? If you see it once, you'll never forget it. Let me show this to you, a video that I have tried to make today. So I'm spending my whole day today making all these videos. Okay, where has it gone? Look at this. If I'm having ethetosis somewhere in the distal half of my body, my hand is going to move like this. It's a slow crawling kind of a movement that you see. Okay. So it was like a snake that was trying to move on a floor. When I see a snake moving on a floor in a three-dimensional view, it moves like this. So it can be a creepy or a snake-like movement that is happening there, right? In the distal limb. That's the ethetotic movement. Okay. Fine. Now, where is the lesion located in? The point here is, to cause ethetosis, where is the lesion in the brain located in? Just remember this, the lesion is located in this part of the brain, globus pallidus. Globus pallidus. Okay. So globus pallidus is a part of the basal ganglia, if you remember, the medial part of the lentiform nucleus. Just now we have made the diagram. So it is having a lesion, it is resulting in ethetosis. Just a quick mnemonic to remember this. GAP, gap. Okay. So G, globus pallidus, P, ethetosis. Okay. So that's a gap mnemonic for ethetosis if you can remember it. Simple. Second one, chorea. Now the second one is very important, that's a chorea. Chorea is defined in the books as a semi-purposeful dance-like movement. Okay, so semi-purposeful dance-like movement, okay, which can be seen in the patient's limb, is defined as the word chorea. Chorea. Now, how does chorea actually look like? If you see it once, you'll never forget it. Sorry, that's not a TikTok video. But most of the time, patients of chorea behave like this only. You can see a dance, you can find a semi-purposeful movement. Okay. So what you find something here is, I'll show it again. The patient maybe intermittently moves the hand like this, okay, and comes out like a, why is it known as semi-purposeful? And now that's important. I have not tried to show that word semi-purposeful here. Look at me on here, right, on the camera. What happens is, suddenly if I want to pick up a mobile phone or a pen like this, my hand should go straight over there. While in ethetosis, it is going to go like a crawling movement. While in chorea, it's going to go like this. Look at me on the camera here. So if I'm having chorea, I'm going to pick up the pen like this. But from a distance, you'll just see me dancing. And look at the word as semi-purposeful. That in the sense that I'm not catching the object properly. I'm just taking the hand there and coming back. Okay. Okay, Prabhu Deva's dance. Fine. Good. You're trying to compare with me. Great dancers, right? I'm happy. Now, to cause chorea, remember this very important thing. The lesion is somewhere looking in the caudate nucleus. Caudate nucleus. C for chorea and C for caudate nucleus, that we know. Okay, C for chorea and C for choric nucleus. This is how we can remember it. Okay, but it's a very important topic. Is that the chorea occurs due to various reasons and causes. The causes of chorea is this. If you look at the causes of chorea, it's coming like a chorea to me. C stands for chorea gravidarum. Okay. H stands for Huntington's chorea. O stands for the oral contraceptive pill, OCP. R stands for the rheumatic chorea that we know. Okay. E stands for the endocrine that we have, cause. And in the endocrine cause, we have with us thyrotoxicosis. That is a hyperthyroidism affecting the central nervous system in a very bad shape. And the last A stands for atherosclerotic. Atherosclerotic or senile chorea. That happens with age, senile thing. So if you know the Huntington's and especially the rheumatic one, rheumatic, there's something which you read in peds also. Yeah. It's also known as a syndonyms chorea. Okay. It's also known as the syndonyms chorea. Now, that's a whole question which has been framed on this topic. The most common cause of chorea, if I look at, is it is a systemic lupus erythematosus, SLE. So there is a disease, SLE, that you'll read in rheumat somewhere, that comes with chorea as a clinical presentation. And remember this, whenever I find a patient of chorea, I think about SLE as a common disorder. Okay, it's not in the mnemonic, that's why I'm putting it separate. The Saint Vitus dance, yes. There was a saint in Christian mythology who used to call the people who are sick and diseased in his church in the morning and for the mass prayer and tell them to dance. Okay, so the things got healed. So Saint Vitus dance, another name for it. Okay. Then we have another one that we know is hemibellismus. There's another movement disorder that we come across with is hemibellismus. Hanging, no problem. With some emesis fugax for some time, don't worry. Hemibellismus is defined to me as a large amplitude, okay, flinging movement that is seen in the proximal limb. So large amplitude flinging movement that is seen in the proximal limb is defined as the hemibellismus. Okay. Okay. SLE, people are asking me the full form of SLE. Oh my God. Systemic lupus erythematosus. There should be a spell check like a mobile in my writing also. Sorry. Poor in English, Hindi medium. Systemic lupus erythematosus. Okay. Large amplitude flinging movement of a proximal limb. Okay. Is this hemibellismus. What is chorea gravidarum? Oh my God. Gravidarum goes with pregnancy. A female pregnant can have chorea. That's known as chorea gravidarum. Okay. Now, how does hemibellismus look to me? Let me show this to you. Look at this. My hand is going too far off. It's a large amplitude flinging movement, and the most important thing out of all is that it's a flinging kind of a movement involving the proximal limb. Okay, so the proximal, the shoulder part, suddenly flings like this. Okay, this is known as the hemibellismus. Okay, some fugax happen, don't worry. Okay, simple. Now the point here is, why is it known as hemibellismus? That's important. Because we find it only on one side of the body, not both the sides. That's why the word hemi came with it. Now, this is something important to know, that hemibellismic movement is on one side of the body, not both the sides. Now look at me on the camera here. We might see patients of athetosis, that's a crawling, chorea, that is dancing, and all these movements usually happen on both the sides. They are bilaterally presented in the patient, while hemivalismus is one of it, which happens only on one side. Okay. Now don't forget, the lesion for hemivalismus is located in this part of the brain, subthalamic nucleus, abbreviated to me as the word STN that we have drawn above. Okay, and don't forget, for this, the lesion is always in the contralateral subthalamic nucleus. So that means the left subthalamic nucleus goes away. Okay, the right will have the problem. If it goes in the right, the left is going to have the problem. So it's always a contralateral subthalamic nucleus kind of a thing. Okay, right. Now, these are all the movement disorders which do come with these kinds of things that are lesions in basal ganglia. Hemivalismus, that's a large flinging movement of the proximal limb. And then we have the chorea, which is a dance-like, athetosis, which is a crawling. Okay. Why unilateral? Now the point here is, it is the lesion which can be an infarct. Infarct are unilateral most of the time. So you find the infarct on one side, not on the other side. So one side is subthalamic nucleus is gone. The other side is working fine. Okay. While if you look at athetosis and chorea, now you'll come in live classes and explain you there better that neurodegenerative disorders or infective disorders, somewhere we find that the cortex and the subcortical areas on both the sides are gone. Like for example, chorea. Chorea is rheumatic chorea. So that the reason or the bacteria causing all this problem of vasculitis in the brain causes on both the sides. So both the sides caudate nucleus are affected. On both the side, globus pallidus is affected. So athetosis and chorea have got a bilateral representation, while this one has almost most of the time get a unilateral representation. Okay. Play again. My network went bad. Okay, I'll just quickly show you everything again. Okay, I'll start with the very first one. Was athetosis. This was a typical snake-like movement. Okay, athetosis. Right. Then we have with us a typical dance-like movement. That is, yeah, that's a typical dance-like movement. That is your chorea. Okay. Then we have another dance, which is done by Sunny Deol maybe. Okay, when he doesn't know how to do the dance, hemivalismus. 2.5 kilo ka haath, you can see it again. So there's a large amplitude flinging movement which starts on the proximal limb. Okay. Right. So that's simple. Now let's move into the disease proper, Parkinsonism. Why does it happen and what are the problems seen in these kinds of patients? It's a very important topic because father of all movement disorder any time is considered to be a Parkinsonism. Parkinsonism. Okay. Okay, some people have named it as Sunnyvalismus. That's fine. Now, Parkinsonism, or being abbreviated to me in most of the books or in my notes as PK. Okay. Why does it all happen? Remember the basic first. In Parkinsonism, there is an atrophy seen in the brain. It's a neurodegenerative disorder. Remember this. Parkinsonism is a neurodegenerative disorder and atrophy occurs. Now, can you tell me, if you know that it's good, what is the most common neurodegenerative disorder? Can someone of you tell me what is the most common neurodegenerative disorder? And if you have attended Dr. Sachin Psychiatry live classroom sessions, very good. He keeps on emphasizing on this part. What is the most common? Yeah, Alzheimer. Remember this, Alzheimer. Alzheimer disease is a most common neurodegenerative disorder that we come across with. I was just checking the spelling of Alzheimer again. But who is the second? Life is a race. Who came first? You guys know him. Second. Second most common neurodegenerative disorder. Yes, that's my Parkinsonism. So my Parkinsonism is the second most common neurodegenerative disorder after Alzheimer, of course. Okay. Now we find atrophy occurs. Atrophy in the brain occurs. But where does this atrophy occur? The site of atrophy to might begin with could be an area for a motor manifestation that is known as substantia nigra, pars compacta, being abbreviated as the word SNPC. So there's a part, substantia nigra of the midbrain, a pars compacta part of it undergoes atrophy. But why does this all happen? Let me draw a transverse section of the midbrain again and try to show you there. So this wala is your midbrain again. As I told you, the anterior part of the midbrain will carry down the corticospinal tracts for me. And just behind that part, there is going to be a deeply pigmented structure. That is substantia nigra pars compacta now. Compacta. Now, what happens in this particular area? Remember this. This particular area is more pigmented, is more contact. So every time I'm making it as a shaded thing because to explain this, that it's more pigmented than the rest of the midbrain is. Now what happens in this part? Suddenly in this part there is a body which deposits, which is known to me as a Lewy body. Now what does a Lewy body actually contain? The Lewy body actually contains a substance inside it which is known as the alpha-synuclein. So have these names in your mind that there is a Lewy body which contains an alpha-synuclein and it goes and deposits in this part. But what is this Lewy body actually? If I look into the microscopic picture of brain biopsy, Lewy body is always defined to me as an intraneuronal, intracytoplasmic, eosinophilic inclusion bodies. So inside the neurons in the cytoplasm there is a eosinophilic inclusion body which are known as a Lewy body. And what does a Lewy body actually end up doing it? It is going to cause atrophy or neurodegeneration in SNPC. What does SNPC stands for? Substantia nigra pars compacta. Where are you? Someone is asking me this. SNPC. Substantia nigra pars compacta. Okay. Now ultimately at that particular point, if there is a neurodegeneration, what do you find? Ultimately at this point, for example, either of the side degeneration can happen. Now what will we find? This particular area, substantia nigra, which was being more pigmented, will become what? Hypopigmented. So there is a hypopigmentation which is occurring at this point. So neurodegeneration causes hypopigmentation in this particular zone. So compared to the normal side, it may become more hypopigmented or less hypopigmented, sorry. Okay. Now how does it impact the patient? Now the point is, how does it impact the patient? If you know, there is a very important neurotransmitter generated here that is known as dopamine. Dopamine works like a kick for me to work, right? Now dopamine has got an effect not in the midbrain. It's being produced here and going somewhere else. It goes into a part, yes, of the basal ganglia which is known as the striatum. Yes. What is this striatum made up of? It is made up of two things. One, the caudate nucleus of the basal ganglia, one, and the second structure it is made up of is the putamen. So caudate nucleus with the putamen together are living in a house and the landlord whose name is striatum. Okay. Now what happens? There is a connection which is there between the substantia nigra and the striatum now, through which the dopamine will like to go up like this. So there has to be a pathway which connects the substantia nigra with the striatum, traveling up with dopamine. The name of the pathway is very simple. Yes, it's a very simple thing in neuroanatomy, where you start with prefix, where you end with suffix. Yes. It's known as the nigrostriatal pathway. Nigrostriatal pathway. So there's a nigrostriatal pathway which is trying to take up the dopamine from the substantia nigra to the striatum part, where it will show its final effect. Okay. So hypopigmentation kind of a thing can occur only on one side. Just for your explanation thing, I've tried to write it on the other side, but it can happen. The substantia nigra on this side is damaged, the other side might be normal. I'll come to that concept. Okay. So that's a very basic thing. Let me repeat this again. Some people are not able to catch with me. It's a very simple thing. Parkinsonism is the second most common neurodegenerative disorder. Whenever I use the word neurodegeneration, I think of atrophy in the brain. That starts somewhere in the substantia nigra pars compacta region. Not exactly starts here, but for the functional disease presentation, it might be seen here. That may impact the patient. Substantia nigra pars compacta sees the deposition of a body known as the Lewy body, which is pathologically known as an intraneuronal intracytoplasmic eosinophilic inclusion body containing a substance alpha-synuclein. And what do they end up doing? Atrophy or degeneration in this part. So that part which was hyperpigmented will go hypopigmented now. So what will happen? The dopamine which was formed here, working in the striatum, passing through the nigrostriatal path will be affected. So what are we going to see in the patient? Decrease in the level of dopamine, affection of the nigrostriatal pathway, and the whole drama now happens. Okay. How are they together? No, they are separate structure. Remember this. They are two friends who are living in an apartment whose landlord is known as striatum. So striatum is a bigger part which accommodates two people inside it. Okay. Now, how does it affect the patient? Now, we'll go into the basics again. Dopamine tries to work in the brain in two kinds of pathways. Remember the pathways now. The pathway number one, which we know is a direct pathway. And the second pathway where it tries to work has got a name as the indirect pathway. So there are two pathways with me, okay, through which the dopamine tries to work. From where does the Lewy body come in from? Okay, I'll come to your doubt later. Where does it come in from? What is the relevance of Lewy body? Lewy body is a neurodegenerative body. If you have ever heard in path somewhere as tau proteins, same like tau protein, there is a Lewy body which can cause any kind of a neurodegenerative disorder. Okay. Now find this out. Direct pathway, indirect pathway. As the name goes, direct pathway gives me a direction. Okay. So it is basically seen to me as a stimulatory pathway. While the indirect pathway on the other end gives me inhibition. So it is always known to me as an inhibitory pathway. So just imagine this in a very simple nature, that I want to do an activity. I want a stimulation. Okay. Like you come for the class, that's a direct pathway for you. You are always stimulated from our side to study, and we'll tell you a deficiency, we'll try to correct it. Okay. But if you don't study, on top of it, listen to all your friends that there is no point in studying so much. The world is going to end. We are going to die of COVID infection. Why to study? That is an inhibitory thing. That's an indirect pathway. Okay. So if you try to take a lot of shortcuts to the indirect pathway, your studies are always going to be inhibited. Now, how does it work? For example, I want to pick up this pen. I take my hand towards the pen. The cortex is getting a stimulation. That's a stimulatory direct pathway. And the moment I stop over there, that is the indirect pathway. That is inhibitory in the sense it is inhibiting the brain cortex. Okay. Now, if I want to do an activity, which pathway should work? Stimulatory, one, direct pathway. If I want to stop an activity, I don't want to do any activity, it is going to be the indirect pathway or the inhibitory pathway. Correct. Now, how does it all work? Remember this. There are two receptors present. One is a D1 and other one is a D2 receptor. Okay. So dopamine works on the D1 receptor, stimulates it. Dopamine molecule works on the D2 receptor and stimulates it. Now please be attentive on this. Is a very simple thing if you try to catch it now. If the D1 receptor is stimulated, which pathway will work? The direct pathway. That means I want to do an activity, correct? So I require a direct pathway. But I want to do an activity. I don't want to stop. So please, can you tell me, what is this D2 receptor going to do for me? Positive or negative? Simple. Positive or negative? Don't worry, I'm taking snapshots. We know your IP address. We are smarter than you. Yes. Negative, inhibited. So I want the inhibition of the indirect pathway and I want the stimulation of the direct pathway. Okay. So direct pathway stimulated and the indirect pathway inhibited. These are the basic things. If I want to do an activity, I should get a direction, stimulation. Not stop there, indirect. Okay. So dopamine works on both the pathways to make the direct pathway work, one thing, and stop the indirect pathway from working. Okay. That's a very simple concept. So look at this now. Dopamine as a molecule works like an initiator of movement. So any movement which I want to do, I want to initiate a movement, I require a kick, and that kick comes from the dopamine. So dopamine works like a kick to start the direct pathway and inhibit the indirect pathway. Simple. Now what is the imbalance like? There are two kinds of stories that we know. Either there is a patient who comes to me with a decrease in the dopamine level on one end, or maybe a patient who comes with an increase in the level of dopamine on the other end. So we got two kinds of different people on spectrum. One has a decrease in dopamine level, one has an increase in the dopamine level. But how does it really affect the patient? Now look at this. If this is the direct pathway, okay, on this side, and the indirect pathway on the other side. So keep on writing this. Okay. Direct pathway and the indirect pathway. Okay. Now please tell me, if at all the dopamine level has come down, okay, which pathway will work more, D or I? My question is for you guys. Which pathway will work more? More, I'm asking you now. Which pathway will be more active now? I or D? If the dopamine level is low, arrow down. Yes, the indirect pathway will work more because it is not getting inhibited by the D2 receptor. Got my point? And the direct pathway will work less because it is not getting stimulated by the D1 receptor. Correct. On the other side, please tell me now, on the other side, if the dopamine level goes up, which pathway is bound to go more in work? D or the I this time? If the dopamine level goes up, which pathway will work more? Obviously the direct pathway, because it is getting more stimulated by the D1, and indirect pathway, it is getting more inhibited by the D2. Okay, right? Clear concepts. Now how does it impact the patient? Now this is physiology. Previously we were at anatomy. Now we are going into neurology. Okay, now find this out. There's a pen, I want to pick it up. My brain signals the muscles of the hand to pick it up. Which pathway should work? Direct. Now suddenly the direct is not working and the indirect works. That means the brain gets inhibited to move the hand. Now what happens? Can I move the hand? No. If at all I am trying to move the hand, there is going to be a very slow kind of a movement because there is a constant inhibition there. Now, can you look at the movement which I am trying to do? Is it slow or fast? Obviously it's slow. If it is slow, what is this clinically known as? Clinically known as, please tell me. This kind of a drama is clinically known as what? Slow movement bradykinesia. That means the speed, the kinetic thing of the movement is very slow. Bradycardia, slow heart rate, bradykinesia, slow movement. Simple terms. On the other spectrum, look at me please. My dopamine level has gone up in the brain. Direct pathway gets stimulated and the indirect doesn't work. So I just think of picking up this pen and my hand goes there fast. Fast. So this movement on the other spectrum will be very fast movement, hyperkinetic movement known as hyperkinesia. Simple. Okay. Now, what is bradykinesia like? Bradykinesia is nothing but my dear friend Parkinsonism. Slow movement. We'll go to the details of it now. What is a hyperkinetic movement? You've just seen this today. I want to pick up this pen. My brain thinks about it. On just fraction of seconds, my hand goes there and comes back. Please tell me which movement have I done? Chorea. That is a semi-purposeful dance-like movement, chorea. Okay. Not dyskinesia, that will be a broader term. Call it as chorea to be more specific. Okay. Simple. So this is what is known as chorea, hyperkinetic movement. What is Parkinsonism is a brady or hypokinetic movement due to fall in the level of dopamine. If you ever read chorea with us later, you'll always realize the treatment is to decrease the level of dopamine or to give a dopamine receptor blocker. Okay. But in Parkinsonism, it's very clear. The level has come down. So either I'll try to increase the level of dopamine by giving dopamine from outside like levodopa, or maybe a receptor stimulator for dopamine. Okay. Now Parkinsonism that you know. Parkinsonism, when I look at the disease proper, it has come to me with the various kinds of disorders or etiologies. What are the various etiologies that we have for Parkinsonism? Let us look at this one and one. The very first link of Parkinsonism always comes from the drugs. Any disorder which comes because of the drug is known to me as iatrogenic. Iatrogenic, that means drug induced. So remember the iatrogenic cause when I look at in Parkinsonism, it can occur in two ways. Either by the use of certain drugs which are dopaminergic antagonists, that means they are blocking the central dopamine receptors for me, or maybe drugs which are eating away the central dopamine, which are known as the dopamine depleters for me. Now when I look at the dopaminergic antagonists, that means they are directly growing and blocking the central dopamine receptor. What are they? One that I know is a typical antipsychotic. Now people are writing antipsychotic, fine, good, but you should be very typical about this answer. Okay, otherwise the examiner will give you atypical numbers. So typical antipsychotic. Okay, if you know the names, good, that's a haloperidol or a butorphanol group of drug, very important. Second happens to be a drug which I know is metoclopramide. Metoclopramide is an injectable oral everything, antiemetic, very famous, metoclopramide. Right. Many more examples and all these drugs are there, but I'm just giving you the chief examples. When I look at the dopamine depleters, yes, now we got few examples with us. One is the methyl dopa, okay, and the second one happens to be a reserpine. So methyl dopa, reserpine are the two drugs. Even one more drug, tetrabenzene, I know that. Just a view on two more drugs which Harrison tries to include in the list, somewhere having a slight dopamine depleter effect also. Two more drugs. One is your amiodarone and the second one happens to be a lithium. So they might also cause Parkinsonism if they're given in a long run, amiodarone and lithium, two more drugs, right? Then we have another cause to remember, that is toxins. Don't forget this toxins now. A lot of toxins are there in the list, but I'll tell you the two main or rather three main toxins that you know. One is the carbon monoxide, okay, and the second wala is the manganese. So carbon monoxide and the manganese are the two toxins which are known to be a cause of Parkinsonism if the patient has been exposed to this. Another toxin, please, I'm just writing the abbreviation, need not go into the full form of it. The name is MPTP. Yeah, it's a good abbreviation. MPTP toxin is commonly developing in one group of people who are known as a heroin addicts. People who take and abuse drug heroin and get addicted to it. So they found that in the long run they're exposed to this toxin developing from their MPTP, and exposure to MPTP, yes, is going to cause all these problems. Manganese. Sorry. Okay. Yeah, it's manganese. You're good in chemistry also. Select. Number 3. Oh, don't go into the full form, my dear friend. It's Ranchodar Shamakdar Chachar, Rancho. MPTP sounds better. Okay. It's not magnesium, it's manganese. Right. Number 3. Number 3 cause is trauma. Trauma. Trauma is something which can happen, especially in a recurrent way, in one group of people who are sports person, which are known as boxers. So trauma recurrent in boxers can expose them to a problem known as Parkinsonism. Okay. Now this is something which we know happened in a great American boxer, Muhammad Ali. He was suffering with Parkinsonism in the later stages of his life due to frequent trauma. Okay. Now, just a word of interest over here, because whenever you understand the word boxers, you carry home a message, it's only Parkinsonism. No. Remember this, boxers can also develop another disease, which is neurodegenerative disorder, Alzheimer. And a big study done on these, they found that Alzheimer disease is more common than Parkinsonism. So remember, in boxers you can have either of the two, but it found that in a study that Alzheimer was more frequent in boxers than Parkinsonism. Right. Then we have number 4 with us. That is a familial or a genetic cause. Familial or a genetic cause with us. Somewhere if I go with the book, that around 5 to 10% patients with Parkinsonism, okay, 5 to 10% of the patients Parkinsonism are known to have a familial or a genetic cause. Now just reading this topic again today, and I found that a lot of genes are there which are new into this now. But for the exam purpose, just remember 2 of the mutations that we know. 2 mutations that we know. One mutation that is known as a Parkin gene mutation. Okay. Second wala is a LRRK2 gene mutation. Now any mutation on a gene has to have a carrier with it, that is a chromosome. For a Parkin gene mutation, it's a chromosome number 6, while for the LRRK2 gene mutation, it's chromosome number 12. Another fine point, how does it come down? What ladder does it take? Parkin gene mutation takes a ladder of the autosomal recessive trait. The LRRK2 gene mutation takes a ladder of an autosomal dominant trait now. Okay. Another quick fact. When does it really present to me? The age of onset that we know. Just a quick fact. The Parkin gene mutation comes to me at the age less than 40 years, while the LRRK2 gene mutation comes with the age group of more than 40 years. So less than 40 if I look at, is something which comes early with me, early onset, correct? More than 40 years comes later in life, which I know as a late onset. So there are two kinds of mutations that we have genetic. Genetic mutations can present with the disease at the age less than 40. Parkin gene, autosomal recessive trait, chromosome 66, LRRK2 gene mutation, chromosome 12, autosomal dominant trait, and most of the patients are above 40. Now the question has recently been asked on it. What is the most common type of mutation seen? In the genetic tree, in the mutation part, LRRK2 gene mutation. Remember this. LRRK2 gene mutation. Okay. Yeah, alpha-synuclein. Now, people with the old photocopy notes are sitting there, or maybe my students from the previous years. I'm intentionally removing alpha-synuclein again because now the mutations are very rare with that. These are the two mains, if you remember. It's fine. LRRK2 and Parkin. Okay. Now another cause. See, what I've written here right now is somewhere at least 2.5 pages of our great Bible of medicine, Harrison. You want to read those 2.5 pages or read only this much is more than sufficient for the exam purpose at least. Okay. Then we have this as a cause which is unknown, known as the idiopathic. As we know, the word idiopathic means the doctor is idiot and the patient is pathetic because the doctor is idiot. Now we find somewhere around 85 to even 90%, some of the books do differ in the percentage, of Parkinsonism patient are of the idiopathic type. Now that's a very standard question. The most common type of Parkinsonism is the idiopathic type. And don't forget, the idiopathic Parkinsonism is also known to me by another name as a Parkinson disease. Parkinson disease, being abbreviated to me as a word PD. And was known to me by an old Greek name also, paralysis agitans. There's an old Greek name, paralysis agitans, which got replaced, okay, that we have now by a new name, Parkinson disease. Actually, all this came with an old name from our literature, that was your Ayurvedic literature. There was an old name. Don't write this, please. Don't write this. Just I'm writing for your information. There's an old Sanskrit name known as Kampavata. There was an old Sanskrit name known as Kampavata, which was replaced by paralysis agitans, which is now replaced by Parkinson disease. Now look at the word Kampa. Kampa means tremors. Vata means metabolic derangement. So there was a metabolic derangement in the patient's brain that resulted in tremors. Kampavata. Okay, Sanskrit name. You should know, guys, you should know Sanskrit. Because if you die and you go to heaven, people speak Sanskrit over there. But for me, it's very simple. If I die, I'll always go to hell. And people speak Punjabi over there. No problem. Okay? Idiopathic. Now, go back to the drugs part, iatrogenic, and write it there. Very simple sentence. Most common cause of secondary Parkinsonism. Most common cause of secondary Parkinsonism is drug-induced or iatrogenic. Okay. So when I have a Parkinsonism with an acquired cause, I'm not talking about the word idiopathic. Okay. It is going to be drug-induced iatrogenic. Okay. People are laughing at the jokes. Fine, good. Someone asked for one thing, which in between he asked for something, some guy, very generous boy, very nice boy. He asked for a break. So we'll just take for synchronization of the classroom. The eMedicosal will just take 2 minutes of break. Okay, and I'll just open my lunch box and start eating my Maggie, which I'll prepare at the end of 2 minutes. Okay. Right. So we'll just take 2 minutes of break. Right. Technical timeout. It's a good name given for it. My God, if a chat box, is seen by any of the parents of yours, they will really beat you tonight. Okay, and your chat box, you are looking at your chat box, what kind of comments you are typing. You are eligible to join one university, JNU. Go and sit there on a dharna. People will be very will appraise or rather like your chatting that you do here. Okay. Oh my God. Okay. I was born in Kanpur and brought up in JNU and living in Delhi. So don't take pangas with me. I am extremists at all the groups. Okay. Let's study. Okay. Now we'll go into the disease Parkinsonism proper. Parkinsonism proper. Okay. Now, when I look at the clinical features of a disease known as the Parkinson disease, which I'll abbreviate as the word PD now, which is a prototype which we take for discussing a Parkinsonism that we have. Okay, so because it's the most common type, idiopathic type. We have got few things here as a clinical presentation of these patients of Parkinsonism. If I look at the Parkinsonism patient, he lives in a life of a trap. TRAP, trap. Now that's a good mnemonic to remember it, right? Uh, T stands for the word tremors. R stands for the word rigidity. A stands for the word akinesia. And P stands for the word postural instability, right? So these are the few classical symptoms of Parkinson disease patient that we know about. Tremor, rigidity, akinesia, and P, the last, postural instability. Now, why this mnemonic track is very important, because most of the time in patients of Parkinsonism or Parkinson disease, when I look at, we can take this like this, one of the earliest or the first symptom they might come to me. In 70% of the cases, we find the earliest symptom of Parkinson disease is often a tremor. Okay. Apart from this, the type of tremor that they face is a type which is known as a resting tremor. Along with this, the frequency of these tremors which are resting are in a frequency of 4 to 6 hertz. Of course, these tremors, when I look at, happen on one side only, unilateral. Okay. And of course, they are more prominent in the upper limb than the lower limb. When I look at these resting tremors, these are few qualities of tremors I'm telling you. And they specifically decrease on sleep. Okay. So the tremor type is resting, 4 to 6 hertz, first symptom, unilateral presentation. It's more commonly affecting the upper limb than the lower limb, and it typically decreases when the person goes off to sleep. Okay, so these are the few qualities of tremor that we know. Fine. Let me show this tremor to you in a video that I've tried to make. First of all, look at me on this live camera. If at all your hand is like this at rest, a Parkinson patient, the hand will always be like this. There's going to be a flexion on the metacarpopharyngeal joint most of the time. So the hand of the patient will be like this, kept most of the time, and he'll keep on rolling like this, as if he's rolling something in between his fingers. That can be a cigarette, right? Or can be a tablet known as pill. So old names were given to it as cigarette rolling or a pill rolling tremor, but a more scientific name is always a resting tremor. For example, a patient of Parkinson will keep on moving, but the most important thing, for example, is trying to pick up a mobile phone. He'll keep on moving the hand like this, and the moment he picks up the mobile phone, the tremor typically disappears. Okay, so this is a typical tremor which is present at rest, not doing in a particular activity, resting tremor. Okay. Now, a student came back with a doubt, sir, you made us write this also. It decreases on sleep. It decreases on sleep. So when I sleep, I rest actually. And in the resting stage, possibly, which is sleep, the tremor should rise. Why does it decrease in sleep? I have no correct explanation for this, but if your logic is correct, that means a patient of Parkinson's disease is somewhere awake, his hand is shaking like this, and maybe when he goes to sleep, he keeps on dancing like this. No. So remember this, I don't have any correct explanation for this, but still they say it always disappears or decreases on sleep. Okay. Now, there are other tremors also in our clinical practice that we all should know about. And what are the clinical conditions that we find them in? Okay, I'll show you some videos which I've got with me recorded today. And I'll try to explain them first there in the video. Then we'll try to write them. Okay. Now look at this. For example, my mobile phone is ringing. Okay, I'm taking my hand towards the mobile phone, but before picking it, every time I look at the screen who's calling me, and on the screen I suddenly find my wife is calling me. My hand will start shaking. Okay, and my hand would go beyond the object also, past pointing. So look at me again. On us just approaching the object, my hand started shaking and it went away from the object. As if intentionally I'm trying to do this drama. This is known as a typical intentional tremor. Okay. So this is known as an intentional tremor. Okay. Which you see in there. Fine. Okay, some people are giving me explanation why there's a decrease in sleep. Okay, fine. Accept your explanation. The reticular formation is cut off. Fine. That can be one reason. Yes. Then another tremor that we have with us is a tremor in which the patient is holding the hand like this and it typically drops down. Like the wings of the birds are moving. Yeah, wings of the birds are moving like this. They are constantly flapping. So that's the name given to it as a flapping tremor. Okay. So you've seen a flapping tremor. Now again I'll show this. When I hold the hand like this, the hand drops down. It can happen on one side, on both the sides. Yes, that's a typical flapping tremor. Another tremor that is very minute, actually, it cannot be seen from a distance. You need to observe it more carefully from a nearby view, or maybe you can peep a paper on the patient's hand and it suddenly fly down. So these are very small kind of tremors that we know as a fine tremor. Okay. So we've got various kinds of tremors with us. We've got fine tremor, we've got flapping tremor, and we have the resting tremor and the intentional tremor with us, right? So where are the conditions that we come across this problem in the patient? Okay, what all conditions do we find these tremors in? The very first one is the intentional tremor. Okay, intentional tremor. Now, if you know, the intentional tremor is typically seen in a kind of a cerebellar lesion. In a typical kind of a cerebellar lesion, we come across with the intentional tremors. So whenever the lesion is in the cerebellum, the balancing organ of my brain, we find the lesion over there is going to cause this kind of a tremor, intentional tremor. Now, there was a question which was image based being asked 2-3 years back in one of the exam like this. Now follow this. I'm trying to make 4 dots and a normal person has been asked to join the 4 dots and make a square out of it. A normal person will always make it like this. Start from one end, start from one end, start from one end, again restart and end. So whenever I'm trying to make a square, by joining the 4 dots, I always keep it like this. That's a normal square. Then we have a lesion that is in cerebellum, resulting in an intentional tremor. How will this patient make the square? He'll start from the origin, end it, and suddenly his hand will start shaking. So the shakiness in the interstitial tremor that we observed in the video also was on approaching the object or nearing the object. Again I start, I end, again the shakiness happens. Again I restart, again I end, the shakiness happens. Again I restart, again I end, the shakiness happens. Correct. So we find somewhere there was a zigzag constantly seen at the edges of the square when I was trying to connect the dots and make a square out of it. Okay, so this was a cerebellar lesion coming to me with a typical intentional tremor. Okay, yeah, it might overshoot also, no doubt. It might overshoot also. Okay. Now we have got another tremor with us, which is known as a flapping tremor. Flapping tremor now. Flapping tremor is also known to me by another name kept in the book as hysterexis. Many of you must be knowing the name hysterexis also. But one more name that you might not know and has been asked last in the exam is a negative myoclonus. Flapping tremor, hysterexis and negative myoclonus are all the same thing. Now why do I call it as negative myoclonus? If you remember myoclonic jerks, I had sudden shivering, or maybe not be the word shivering, a sudden jerk of the body that was myoclonus. If you remember the first video that we have seen in the epilepsy class, second class, there was increase in the tone of my body. That was positive increase. The tone increased that resulted in a jerk movement. For example, if I'm holding the hand like this, I'm trying to increase the tone of the muscle to hold it. If the tone decreases, what will happen? The hand will go down. Again, it will come back. So what makes it go down is this. There is a sudden decrease in the tone of the muscles of the hand that occurs. Now look at the word negative. The word negative means sudden decrease in the tone of the muscles which are holding a limb in a particular posture. So we have a name here kept as negative. The word negative came because the tone in the muscle group suddenly decreased. That was the word negative. Because myoclonus, always all the time we find there is increase of the tone. It is always positive, while it's on the other spectrum negative now for me. Okay. Now we find that a flapping tremor is also seen, or rather seen, in conditions known as hepatic encephalopathy. So there is a disorder known as hepatic encephalopathy, that is a liver failure affecting the brain. Another brother of it is uremic encephalopathy, in which the renal failure affects the brain. And third one is the CO2 narcosis. That means a disease known as respiratory encephalopathy. That means the carbon dioxide collects a lot, affects the brain centrally, CO2 narcosis. Another name for respiratory encephalopathy. Hepatic, uremic and CO2 narcosis. All these three conditions result in a flapping tremor, hysterexis or a negative myoclonus. Okay. The last tremor which I have shown you was a fine tremor, fine tremors. Fine tremors are seen in patients with thyrotoxicosis. Remember the name, thyrotoxicosis. That is again the hyperthyroidism affecting the central nervous system. Okay, thyrotoxicosis. Right. So these are few tremors that you all should know about. Commonly asked as a differential diagnosis. If you see these tremors, what are you thinking about? Now, there's another very important topic, yes, known as an essential topic, better known as the word essential tremors, ET, essential tremors. Now, this is a very essential topic to read, like status epilepticus, improve my status. This essential topic is very essential for the exam. Now remember this, it's a most common movement disorder. So when I look at all the movement disorders that I've got with me, out of all the movement disorders, essential tremor happens to be the most common movement disorder. Now, few essential points on this. The essential tremors, when I look at, come down in the family tree in the autosomal dominant trait. So autosomal dominant inheritance of the disease is seen with them, right? And around 50% of these patients have the disease coming down in the family tree, taking a ladder down of autosomal dominant trait. Apart from this, the disease, when I see these tremors, are in a frequency of 6 to 10 hertz. Now look at this. Someone was asking, what do you mean by 4 to 6 hertz? Actually, the frequency of a tremor can be easily seen through a different instrument. When the hand shakes maybe 4 to 6 times in a second, it's 4 to 6. If it shakes 6 to 10 times in a second in an oscilloscope measurement, it becomes 6 to 10 hertz. Just remember the figures, that's more than sufficient for you guys. So the tremor, essential tremor, are much faster actually. The frequency is 6 to 10 hertz. Parkinson was just 4 to 6 hertz. When I look at when I look at essential tremor, the representation, or rather the presentation of these tremors is on both the sides. It's bilateral. Parkinson, if you remember, I wrote it with you. It was only on one side, unilateral, while this is on both the sides, bilateral. Along with this, they are equal also, that we find. That means they are symmetrical. So they are symmetrical, equal on both the sides, and bilateral. Okay. Few extra points. They commonly affect the upper limb, followed by the head, the voice, and then the lower limb that we can see. So we find somewhere the upper limb part of the body is more frequently affected, and the least frequently affected in this order is the lower limb part. But 50% of these patients have got the disease not at one point in the body, they have got the disease at multiple sites. So these tremors happen on multiple sites in around 50% of these patients. Okay, now what is the difference between fine tremor and essential tremor? Simple concept. Remember this. These essential tremors have got an origin in the brain, an area in the brain where they originate from. The area of the brain that they originate from is the cerebellum. So there is a lesion now in cerebellum sitting for these patients, which create these tremors in the patient, essential tremor. Now you might again catch me and ask me, sir, that why not intentional tremor? How are they different from my intentional tremor that you showed in the video? Remember a very important point on essential tremor. They are paroxysmal, or they might be episodic, because they typically increase on anxiety, yes, and decrease on taking alcohol. So that's a good thing. It increases on taking stress, and it decreases on taking that something which decreases my stress, alcohol. So can you tell me a good treatment now available? No, my dear friend, it's not alcohol, it's not char bottle vodka. It's beta blocker, propranolol. Remember this, the drug of choice for patients of essential tremor is considered to be this beta blocker, propranolol. But if the propranolol is not working, that means the patient on propranolol therapy has got no response, then we go with another old anti-epileptic agent. This name is primidone. Okay. Or maybe still, if there is no response, then we might go in for a central nervous system stimulation known as the deep brain stimulation in these patients. Most of the time, most of the patients that I've seen in my clinical practice with essential tremor, most of them have been treated with propranolol very well. Another drug is primidone, which we give, okay, which can help the patient. Now, deep brain stimulation of an area. Now, need not go into details for this, just remember the thalamus word. So, thalamus is the area that is taken for these patients. Yeah, the deep brain stimulation. Now, how does it look like? Now, students are asking, how does it look like? I'll show you this. For example, these are the 4 dots, and you have to join and make a square now. and I give you a thing which will cause anxiety. I'll announce in the class, rumor. It's totally a rumor. Don't worry. It's totally a rumor that I have got a piece of information we need that our examining body, national board, the governing body, the NMC, and the big boss Supreme Court have decided that this COVID pandemic may or may not end. How will we conduct the entrance NEET PG? Problem. So they decided to do one thing. No more entrance exam this year. Good. That's a good news for you. But how are you going to get your PG seat? Based on your marks of MBBS. Just imagine. If such a decision comes for you overnight, you will only have one thing, anxiety. And in anxiety, if at all, you want to join the 4 dots. How are you going to do it? Sir, what bad news have you given me, sir? What will I do, sir? Please refund my fees, sir. Now I will go and prepare for MBBS entrance, sir. That will be a better thing. Okay. So if such a rumor spreads somewhere, you'll have a problem like this. Okay. So there's a zigzag while making a square like this. It's very simple. Essential tremor. Thalamus has got a nucleus where you want to go in for stimulation. Ventro-intermediate nucleus of thalamus. So VIN is an abbreviated name for this. Ventro-intermediate nucleus of thalamus. Okay, is something which is taken up for deep brain stimulation in these patients. Okay. Now someone was asking me voice. In voice, it happens. Yes, if I call you on the stage and tell you for extemporized speech, obviously your voice will be always shaky throughout it, no? Okay. Now, there's another sign that we come across in Parkinson. I've done with the tremors part. There's prognosis and complications. Okay. Oh. Prognosis is good. They live a normal life. There's not much of complication of this problem. Only if it is very severe, it might cause muscle fatigue, heat exhaustion, and all these problems. Okay. Why thalamus leave that story? Because thalamus tries to project everything into the brain now. It works as an inhibitory center also. So you can inhibit these kind of things not by inhibiting the cerebellum, by firing the thalamus. If I send a signal from thalamus, some inhibitory signal might go there and stop it. Okay, I'm not going into details, please. Okay, there's no video for essential tremor. I'll make a video tonight. I'll show you tomorrow if I can make it. The second thing as a sign in Parkinson is rigidity that we come across with. Rigidity is something that we find in these patients, in which resistance is seen in the patient to a kind of a movement that we do on him known as a passive movement. So there's a movement that we do on the patient's joint, either flexed or either extended. Okay, this is known as a passive movement and the patient doesn't spend any energy on it. I spend on him is a passive movement that is known as a word rigidity now. Okay, it's very simple. If I move my joint, elbow, flex or extend, it's active. You come and do it on me, it's passive. Now how does this all rigidity look like? Oh my god, I just stopped this. Okay. Some people are asking for MCQs. Why? We'll do it tomorrow. Don't worry. We'll do it tomorrow. Today I will not be doing any MCQ because the topic won't complete. Okay. And tomorrow the MCQ you will get in the app by tonight most likely. I'll be giving a test paper which will have questions on seizure, headache, myasthenia, CNS infection, 4 topics and Parkinsonism also, the topics that I've tried to take out today. Maybe 1, 2, 3 things will be extra which we'll do tomorrow. Don't worry, you can leave that also. You can just go back and solve that questions and come for the test tomorrow for a discussion also. When I complete Parkinsonism, everything, I'll go for the discussion of those questions. Okay, it's 1.5 kilo ka hath. No, it's 2.5 kilo ka hath. Now look at this. When I try to extend something in the patient's elbow joint, okay, I find a resistance all throughout. And it seems as if I'm molding a pipe made up of lead. So this is known as a word lead pipe rigidity. As if I'm molding a pipe made up of lead. So it's continuously same throughout when I'm trying to move the joint. Okay, that's known as a lead pipe rigidity. That's simple. Then another term that you all should know about is this one. Yeah. And I flex when I extend, I find the gap coming in between. As if I'm trying to travel in a bullock cart and the wheel of the bullock cart is rotating like this with a gap coming in between. The wheel of a bullock cart is a cogwheel for me, so it is known as a cogwheel rigidity with some interruption coming in between, inflection as well as extension, right? Then we have another kind of rigidity, that is this. Yes, it's not lead pipe. When I try to extend the limb, I might find rigidity, and the last part it suddenly opens up, as if I'm trying to remove a knife or a sword from a clasp. Okay, so I apply a lot of pressure and it suddenly gives away at the last part. That's known as a clasp knife rigidity. Okay, so it's very simple. Some people want to see it again. This is same throughout in extension and flexion that you come across the lead pipe rigidity, right? This one comes with an interruption in between, that is your cogwheel rigidity. Okay, and this wala is the rigidity which is present initially, and the last part it comes in. That's a clasp knife rigidity. Okay, so that's simple, easy. But what all conditions do we come across with all these kinds of rigidity? Let's write them down now. No, there's no fugax, don't worry, I'm just changing the screens, that's why it's happening, don't worry. When I ask you guys some question, you don't answer and type them. If you see a black screen, you start typing, you know, what happens to your speed? Lead pipe, cogwheel, and the last wala is the clasp knife rigidity. The clasp knife rigidity. Now if I look at the lead pipe rigidity, remember this, it is seen in extrapyramidal disorders or extrapyramidal syndromes. So most of the extrapyramidal syndromes that we come across with are having a lead pipe rigidity, being abbreviated to me as a word EPS. While on the other thing is a cogwheel. Parkinson disease is a perfect example for a cogwheel rigidity to be seen. And the last one is a clasp knife which is seen in an upper motor neuron lesion known as a UMN lesion. What is UMN? That stands for the upper motor neuron lesion. Upper motor neuron lesion. A basic anatomy again. If it's an upper motor neuron lesion, what tract is actually involved in the patient? The same tract, the pyramidal or the corticospinal tract is gone. So in a pyramidal injury, we have this problem. Now, a question came by the examiner, why does a Parkinson patient? Now look at this. Parkinson by nature is an extrapyramidal syndrome, yes. But in these patients, we don't find a lead pipe rigidity. We commonly see a cogwheel rigidity. Why? Why? The reason is very clear. Look at me on the screen right now. It's going to be same throughout. Yes, lead pipe. But suddenly what happens when the tremors come on it, it becomes a gap-like feeling coming in between. I'll show the video again for a better understanding. So what happens in a cogwheel rigidity? The tremors, or rather the resistance, is same throughout. But when the tremors come and superimpose on it, it always give a gap-like feeling to me, right? Oh, internet open. Okay. Now, I'll just show this in a very simple diagram. it is same throughout, great. But in patients with Parkinson disease, it comes with a gap coming in between. Look at this now. It is same throughout, that is your lead pipe rigidity. With a gap in between is a cogwheel rigidity. So what are these gaps now coming? If I take this R as a rigidity of the resistance, these gaps are created by the superposition of tremors now. So tremors coming on superposing on the rigidity phenomena make the rigidity go lead pipe to a cogwheel type. It's very simple. Now the advantage that the examiner took on this concept was this. In a Parkinson disease patient, when I look at them, what kind of rigidity do you find in the upper limb? What kind of rigidity do you come across in the lower limb? Now find this out. In the upper limb, the rigidity that we find in these patients is typically cogwheel. Is typically cogwheel. But in the lower limb, remember this, the rigidity most of the time is seen of the type lead pipe. So it's a lead pipe kind of a rigidity that you find in these patients in the lower limb. Why? Because this time what happens is the tremors are missing in the lower limb. We wrote it earlier. Tremors are more predominant in the upper limb. So wherever we are going to have tremors, there is going to be interruption while moving the limb, and the lead pipe will convert to the cogwheel type. Where you don't have the tremors, it is going to be a smooth movement which is of the type lead pipe. Okay. Now there's another concept that we have. That is, what is the difference between rigidity and spasticity? You will cover this topic again somewhere in your physiology classes. Ma'am will explain this better. What's the difference between rigidity and spasticity? Remember this point. Tone increases in both of them. We'll write the point here first and then show you the videos related to this. Tone increases in rigidity and spasticity both. But the tone in flexors is equal to extensors in rigidity. In spasticity, the tone in flexors is always more than the extensors. So write this down. Okay. So what we find is the flexors and extensors of the limb, both of them have got equal tone, that is rigidity. While in the spastic phenomena, the tone in the flexors is more than the extensors anytime. Write this down also. The tone increases in both the muscle group which are opposite to each other. So the problem of rigidity is in both the directions equally. It's bidirectional. I'll show you the videos, just keep on writing. While this happens in one direction more commonly, it's unidirectional. And write this point. Spasticity phenomena is considered to be velocity dependent. So spasticity phenomena is something considered to be velocity dependent. Okay. Now what do you mean by all this drama? What is the meaning of this increase of tone in both the direction equally and in one direction? Right. I'll show you the videos related to this concept. Okay. When I extend the limb, when I flex the limb, I find in the patient the tone is equally increased. Why? Because flexors and extensors, both of them have got increase in tone. Look at me on this video, on the camera. So suddenly when I flex, the extensors opposite. When I extend, the flexors opposite. And the tone is increased in both the muscle groups equally. That means it's going to be a bidirectional kind of a thing. In both the direction, I find the tone increasing equally or the resistance equally. When I extend, when I flex, I'm going to find the tone equal in both the movements, equal bidirectional, right? Another concept was spasticity. How is it different, spastic phenomena? First of all, look at a spastic limb. If you imagine this as a spastic limb, suddenly you're going to have flexion of the elbow most of the time. That means the flexor muscle group in the forearm has got increase in tone. Okay. That's my daughter's car below. Okay. Now look at this. When you extend the limb, you're going to find a lot of resistance. But when you flex, you don't find it at all. So that's the difference. On extension, I find it. On flexion, I don't get it. Tone is increased only in the flexor group of muscles, not in extensors. That means when I'm extending the limb, the flexors are opposing it, correct? But when I am flexing it, there is no opposition at all. And find this out again. When I extend the limb, the tone keeps on increasing. As I keep on extending the limb, the tone keeps on increasing. It is known as a word velocity dependent. That means as I keep on moving, the tone is going to increase. Correct? Tone is not going to increase, sorry. The resistance that I find on this kind of movement will keep on increasing on movement of the limb. That's why the word velocity dependent comes with us. So these are two terms that you all should know about: rigidity and spasticity. Now let's look into the patient of Parkinson again. Yes, rigidity is bidirectional in a sense that in both the flexion and extension the resistance will be equal. Yeah, most of the times I keep this word spasticity for a clasp knife rigidity, right? Because you know what happens, spasticity is seen in a UML lesion. And what happens in a UML lesion? A clasp knife rigidity. Right. Now gait, something very important, gait. Gait in patients of Parkinson disease, don't forget, is of the type which is referred to me as a word fascinating gait. Fascinating gait. Right? Now, what is the meaning of the word fascinating now? You should know this concept. I'll show you some videos with me. Okay. Like a patient of Parkinson, whenever standing, okay, is standing with a stooped and a flexed posture like this, because he's having a lot of rigidity in his whole body, and he's having a stooped flexed posture like this, and his hands keeps on rolling all the time in resting stage. That is a typical resting tremor. Now when the patient starts moving ahead, the problem is because of the resistance, the leg that he has to take ahead in the swing phase of the gait cycle, he is not able to take that. For example, in a particular swing phase of the gait cycle, I might take my foot this much ahead, but this patient will only take this much ahead, maybe just 1/4 of my total length covered in a single step because of all rigidity. Now find this out. This patient is typically going to walk like this with a very small steps. Trying to maintain the balance, having a resting tremor, right? Some of the authors, yes, do write the word shuffling over there, because when we play cards, they shuffle like this, they're faster, okay? So that's known as a fascinating. Why the name fascinating came for it? This is important, because this patient is trying to run. In order to match my speed while running, he is taking small steps much faster than I take. The word festin means ready to run somewhere. For example, right now in the lockdown period, I am at home. All the time in my house, I walk like this, ready to run. Because I know my family members, they're going to give me some work, homework, work at home as they say. I'm walking very slowly. But suddenly in my house, whenever I heard my wife calling my name, I disappeared from the particular situation. Look at this. Earlier video, my walking was very slow, correct? Now suddenly my walking became very very fast. It's just the ulta, or the paradox of the movement that we just now saw, is known as a word kinesia paradoxa. Correct. Write it down. So we got another thing in patients of Parkinson, along with the typical fascinating gait. It's known as a term kinesia paradoxa. इतनी सारी trophies you are worried about. Oh, first of all, who is the patient? Of course, me. 2 years or 1.5 years back, we recorded this video in Somesh's chamber, and that's why I'm wearing a sweater. As they say, winter is coming, right? Kinesia paradoxa. And the cameraman was none other than Sumer sir. A radiologist can record anything very well. Now, what is the meaning of the word paradox here? There is increase in acceleration on running. So if at all you get a good rank in any of the exam, you have to come to Delhi to give a personal interview with us. And that was the Sumer's chamber where he sits most of the time. So, right. So that's your dream destination at least. As they rightly say, no, kabhi aao haveli pe. Okay. So there is increase of acceleration on running suddenly. It's known as a kinesia paradoxa. For example, I'll just give you an example. Like these patients of Parkinson's are actually players of the cricket IPL team RCB. Whenever they are playing, whenever they are moving on the ground, they are so slow, fascinating. But whenever they're going for an act shoot, especially the Virat boy, Virat Kohli and all, they get kinesia paradox. They start running towards it. Okay, so RCB. But looking at the COVID epidemic, I think so the Mumbai Indians are always on the top of the charts. Sad story. And RCB is losing. That's good for them. But to my surprise, in the COVID ranking, Delhi Daredevils, yeah, it's a great thing. God bless India. Another gait that we find with us is a circumduction gait. Okay. Now, if you know this circumduction gait, is this seen in typical patients of hemiparesis. Hemiparesis. The word is half and the word is paresis. That means the half body is weak in the patient. Now, if you look at a patient of hemiparesis anytime, he is having a lesion in the brain known as a corticospinal tract. Anywhere in the corticospinal tract, he's having a problem. Please remember this. Because of this, there is a weakness that comes in the patient, quite often distal, more than proximal. Remember this. Along with a sign which is known as spasticity. So some people are not very clear with spasticity. I'll explain this again in this video. So there is a hemiparesis seen in the patient, which is more weakness seen in the distal than the proximal muscle along with spasticity. An additional point to write here is the weakness is more in the upper limb than the lower limb. So follow this term. Half side of the body is weak hemiparesis. The lesion is in the corticospinal tract, causing weakness more in the upper limb than the lower limb, more distal than proximal along with spasticity. Okay. Now, why is it known as circumduction? Now this is important. Follow the video, please. Now, first of all, a patient of one-sided body weakness, hemiparesis, will always stand like this. For example, my right side is weak. I'm having weakness on the right side. You can see me on the screen on this video. I'm flexing the elbow and extending the knee joint. So there is a flexion in the elbow joint and there is extension in the knee joint. Now, please tell me, if you see this patient like this, what kind of rigidity will I call it as? I've discussed this in the very first class. Should I call it as decorticate rigidity or the decerebrate rigidity? You can just type the O or the E. Decorticate or decerebrate, O or E? Please tell me. Flexion of the upper limb with extension of the lower limb is always known as a decorticate rigidity. Remember this term. Yes. Okay. Now what happens? Upper limb is flexed, the lower limb is extended, and the whole side, the right side of my body, is having a problem of spasticity and weakness, of course. So how will I walk? I'll take the support of the normal side, right? Lift up the normal side, drag the foot on the floor and make a round circle like this. So every time I'm walking ahead, I'm making a round circle like this. As if I have become a compass, taking the support of the needle and rotating the pencil over it like this, round, making a half circle, circumduction. Why this movement happens? Because my foot muscles are really weak. I cannot move them at all. But my hip muscles are fine. I can lift up the weak side, take it up, rotate it round and keep on moving like this. Now I'll play the complete video like this. Making a half circle every time, circumduction. Now the thing that you need to notice here is very important, is that when the weak side is landing down on the floor, I'm not falling down. If the weak side is landing down on the floor, I'm not falling down. I'm keeping it stable, lifting the normal side and again rotating it, again keeping it down the weak side, moving the normal side, again rotating it. Yes. What is there on the weak side? Can you guys tell me what is there on the weak side which is helping me to hold it on the floor? It's weak. It's weak. But what is there on the weak side which is helping me to take the support on the floor? Can you tell me? Spasticity. Look at this. Yes. Spasticity is considered to be good. Write it down. Something which has been asked quite recently. Spasticity is considered to be something good. Or rather I can use the word as beneficial. To maintain balance. To maintain balance while walking. So remember this concept. While walking, to maintain balance in a patient of circumduction gait, if they are having spasticity, it's considered to be good to maintain the balance on them. Okay, they will not fall down. Another interesting gait to write it down is a waddling gait. Please remember the name is waddling gait. So there's a gait with us known as a waddling gait. Why does waddling gait happen? Remember this term, myopathy is a disorder. The word pathy means a disease. The word myo stands for the word muscle. So there's a disorder known as myopathy which comes to me with a waddling gait. Remember this small clue that will really help you. Most of the myopathies that I know are proximal myopathies. That means the hip muscles are really weak, right? Now what I want to show you in this video, why is it known as, someone is asking one question, kinesia paradoxa is seen in Parkinson disease only. Okay, write it down. Parkinson disease will show kinesia paradoxa. Now see this. If my hip muscles are weak, suddenly what will happen? When I take the right leg ahead, my right hip will fall down because the muscles on that side is weak. When I take the left leg ahead, the left hip muscles will fall down because that side they are weak. Now look at this. When I'm taking the right leg ahead, my right hip muscles are falling down. If I would have fallen on the right side, I would have really fallen down. That means if my trunk has gone to the right side, I would have fallen down. Now look at my trunk. It's gone to the left side. When I take the left leg ahead, my tongue goes in the opposite side like this. Yes, I'll play the complete video. So watch. Yeah. If I upload it on TikTok, yes, I'll have more followers than anyone else. Okay. This is known as a waddling gait. Because if you've seen some aquatic animals like penguins and ducks, They keep on walking like this. They waddle all the time like this. A typical waddling gait. All these videos are there with this in the eMedicos app in a separate section. I've done a voiceover also there. You can just go and see them once again if you missed a part of it. I recorded all these things because somewhere every classroom I used to walk on like this, and after the class I used to myself feel I'm having some disease. And one great student in a corner recorded all these things and put it on YouTube next day. And suddenly my wife saw me walking like this. She just gave me sympathy. That for making money, how much hard work are you doing? You're a good husband. Good. Now, let's follow this, the gait disorders. We have got another gait with us, which is known as a lurching gait. Now, follow this name, lurching gait. The lurching gait is seen in patients with poliomyelitis, polio. So there's a disorder known as the polio disorder, which has got a typical lurching gait. Okay. Now, polio is, if you at all read in peds and community medicine, you'll come across that the lesion is at the anterior horn cell. So there is a lesion in the anterior horn cell. The AHC stands for the anterior horn cell. There's a lesion right over there. And these patients are having a constant wasting on one side, okay, of the muscle tissue. That's why they lurch to one side. Now, why do I call it as lurching? What's so different here, lurching? I've shown this a video. That will be better to explain this. Okay. Now, if at all I'm having polio and the affected side of my body is on the right side. So what we find, I'm going to bend towards the weak side. Take the support by keeping my hand on the weak side, maybe the thigh or the knee joint, right? And walk by bending towards the weak side and taking its support every time like this. So you found a difference. In the waddling gait, I was moving like this, like this, like this. But in lurching gait, I'm just bending towards one side more frequently. Okay. Someone is asking one doubt, I don't know the answer correctly. Is pregnancy having a waddling gait? I don't think so. They've got a lordotic posture. Do they really waddle like this? I should see the patients better. Okay. So that's a lurching gait with us. Easy gait. Another important, interesting gait that we have. See, I'm not going into the Trendelenburg gait because in orthopedics, Bahubali, Dr. Tushar, whenever comes, he'll explain that thing better over there. I'm not going into the Trendelenburg thing. I'm just giving you neurological view disorders and the various kinds of gait that we find. Okay. Then we have another gait with us, which is known as a broad-based gait. Broad-based gait. Broad-based gait is seen in patients with cerebellar lesions. So remember, this word broad-based gait is seen in cerebellar lesions. Okay. Now, if you know, the cerebellum has been an organ in the central nervous system to maintain my coordination and balance. And why does this whole broad-based thing comes into it? It's very simple if you look at the video. If at all, by chance, you drink and you drive, correct? And it's a very common scenario that when you drink, you want to drive because in Hindi, as they say, "Gadi aaj tera bhai chalayega." And a police wala outside will obviously catch you by smelling you or making you blow on the alcohol meter. But suddenly, you don't have that equipment, or maybe you're in Europe or America, they will call you outside the car and make you walk on a straight line by keeping the feet one ahead the other one. That was a tandem gait walking. Now, if at all I am drunk, first of all, one line in front of me on the road will look as two lines, and I'm trying to walk on two lines now as an illusion. How am I going to walk? Like this. So whenever I'm drunk, or rather you are drunk, you're going to walk like this. Okay. So that's a typical gait known as a drunken gait or a broad-based gait. In the broad-based gait, the concept is this: to maintain the balance, I keep my feet wide apart. The base of the gait is very broad, the base part. And look at me, I'm falling towards one side. Now that's the connecting part. Whenever you have a cerebellar lesion, you have a tendency to fall towards the side of the lesion. Okay, so this is something known as a broad-based drunken gait. Don't forget this one. Very commonly seen in our Saturday nights in hostel rooms, in the boys' hostel especially. Yeah. Now, apart from this, two more gaits to add here. Yes. One is a high steppage gait. High steppage gait. Other one is a stamping gait. High steppage and a stamping gait. Okay. Now, high steppage gait, remember this, write it down, is a gait disorder which comes in a foot drop injury. So there is an injury in the nerve known as a foot drop. If you know, this foot drop comes due to a peroneal nerve injury. Peroneal nerve injury. So there is a nerve which supplies the foot, peroneal nerve, and due to some disorder, neuropathy, anything, it has been cut off from its supply, or rather the supply to the foot muscles is not going. Okay. Stamping. Now this is something important. Stamping gait. Stamping gait is somewhere seen in patients of posterior column lesion. Now write this down. In posterior column lesions, we typically find a stamping gait. Okay. So why do we call all these things as high steppage and stamping? I'll show you this video to you to explain this better over there. Okay. Look at this one first. I'll just pause and come back here. Oh, let me pause first. In a foot drop, the problem is the foot drops down. It doesn't dorsiflex at all. So what happens is this. When I take my leg ahead, in the swing phase of the gait cycle, every time I have to dorsiflex the foot, correct? But this time the foot doesn't dorsiflex. It is always hanging down. So in order to dorsiflex the foot, I keep my foot high above the ground. Now the word is high steppage. When I take my step ahead, the foot goes high above the ground. Why? To dorsiflex the foot, which I cannot do in a condition known as a foot drop, peroneal nerve injury. So it is known as a high steppage gait. Very simple. Okay. But someone looked at the video and told me later, so when you're hitting the foot on the floor, you're hitting it hard. Is it not the stamping gait? No. There's a bit of difference between the two. Let me show you this difference. In the stamping gait, the problem is posterior column. If you know, the posterior column is conveying an impulse of vibration to the brain, correct? Now what happens? This is a posterior column lesion. The vibration to the brain doesn't go up. So what do? I keep on looking at the floor, predicting the distance, and keep my feet much firmly on the floor like this while looking at it all the time. Why? Because when I kind of walking on the floor, whenever I kind of do a walking on the floor, I keep my foot on the floor, I can feel the floor. Because when the bones hit the floor, a vibration signal comes there and tells my brain that I've landed on the floor. Okay. And that vibration signal goes to the brain. Okay. Goes to the brain with a posterior column. So what happens now? There's a posterior column lesion. I cannot feel the floor. I can look at the floor, predict the right distance, and keep it much firmly on the floor like this. This is known as a stamping gait. Okay. Great. People have got in the chat box. Some people are not looking at the mobile. They're looking at the clock. Time is up. Get out from here, sir. Okay. So sometimes the class ends well on time. Inside I'm very emotional. That why has it ended? We should teach sir more. But outside I'm very happy. Because happiness comes when all is well, and all is well comes when you don't have to study well. Okay. Doubts and queries, I'll put some quote again today in the Facebook group. Okay. So rest in peace, Irfan Khan, a great actor. Okay. I still remember I met him long back in my school days. He was in one serial he was being was acting in Chandrakant, I remember. Okay, good night. Stay home, stay safe. Tomorrow again we'll come back again. And please remember tomorrow we are going to have a test. By midnight I'll just cross check it once. By midnight I'll upload the questions which are around 50 questions. Okay, some questions of Parkinsonism on the topic that we have not covered might be there. So don't panic on seeing them. And don't blame me, sir, you did not teach. Why are you asking questions? They are very simple kind of things. Just solve it once, and if at all possible tomorrow, you are cooperative, I am energetic. We are going to discuss all the questions there also. Okay? So, good night. Stay home, stay safe.